Good morning, good afternoon, and good evening. Welcome all of you to the live program number 129 at Orthopaedic Principles. Today, our guest of honor is distinguished faculty Dr. Selene Parekh from Duke University, North Carolina, United States. Dr. Parekh is a graduate of the Boston University School of Medicine, and he later completed his internship and residency at the Hospital of the University of Pennsylvania. He completed an MBA in Healthcare Management at the Boston University Graduate School of Management, Boston, Massachusetts, and also a fellowship in healthcare entrepreneurship at the Wharton School of Business, Philadelphia, Pennsylvania. Dr. Parekh was a foot and ankle surgeon at the University of North Carolina initially, and later joined the North Carolina Orthopaedic Clinic and Duke Orthopaedics in 2009, where he currently serves as the professor of orthopedic surgery. He's a co-chief of the Foot and Ankle Division and also adjunct faculty at the Fuqua School of Business, Duke University, North Carolina. So today, it's my great honor to introduce you to Dr. Selene Parekh for this wonderful lecture on total ankle replacement. Over to you, Selene.
Thanks, Hitesh, and as you said, good evening, good morning, and good afternoon for everybody around the world. We're going to be talking about ankle replacements. There's been increasing global interest in ankle replacements over the last decade. We have garnered a lot of experience at our institution amongst our faculty, and we're sharing some of these things with you today. So, you know, in the 21st century, we have smart glasses, we've got smart contact lenses, there are spoons that patients can use who have Parkinson's to stabilize their tremors, there's smart clothing that people can wear, and we have autonomous vehicles from Tesla to Lexus to Mercedes, and smart watches where we can have the power of a whole computer on our wrist. And so why can't we have something smarter for ankle arthritis? And so, you know, if you think about it, life has really transformed and will continue to transform. If you look at this video, this is augmented reality, which is coming our way right now in the gaming industry, but will change what we do in the operating room and will be part of the total ankle process. But you know, why not have ankle replacements? Why not adopt this new technology? What is the resistance? You have athletes from around the world who have these ankle sprains and ankle fractures, whether it's through sports, whether it's through extreme activities, even daily activities, motor vehicle accidents. We should be able to offer them options for ankle arthritis that are above and beyond just ankle fusion. Now, we know end-stage ankle arthritis is extremely painful for these patients, whether it's post-traumatic, whether it's primary, whether it's rheumatologic-based. And there have been studies showing that end-stage ankle arthritis is as severe, if not more severe, to your quality of life than end-stage hip disease. So this is a big deal for a small joint that oftentimes gets neglected. Well, so why do we want a total ankle replacement or arthroplasty? Well, patients have debilitating pain. They can have large bone loss. They can have adjacent joint disease. They can have bilateral involvement. And so what we're looking for is to provide them with some type of restoration of their normal anatomy, of quality of life. We want to be able to relieve pain and preserve joint motion and stability. So we can take patients like this patient with a fairly straightforward ankle arthritic joint, something like this that has post-traumatic ankle arthritis with lots of hardware, patients who have large varus deformities or valgus deformities, and we can now give them an ankle replacement. Now, ankle replacement is still not the norm. It is increasingly becoming popular, but it is still not the global norm for the treatment of ankle arthritis. If you look at 2018, the data shows that only 8,000 total ankle replacements were done in America. That is far less than the volume of ankle fusions, ranging from 20 to 23% back in 2010. And I would venture that that number is not too far off with the more recent numbers. Now, the problem with patients who have ankle fusions is, by and large, most of them have a limp. They can develop adjacent joint arthritis over the course of years. Now, whether that's symptomatic or not can be debatable. And if you look at the literature critically, there are a large number of patients who still feel like that is not a satisfying outcome for them. And so when you see patients with ankle arthritis, you want to really go back to your basics. You want to do a good history and you want to do a physical exam. You want to understand the reason for their ankle arthritis, whether it's degenerative from post-traumatic ankle arthritis, or they have ankle instability, or like I said, an underlying inflammatory condition. You want to make sure that you have completed and exhausted all non-surgical options, from anti-inflammatories, steroid injections, PRP, stem cell injections, bracing, physical therapy. You really have to exhaust this before you take these patients down the path of a surgical intervention. And then when you examine them, you really want to start thinking about where their prior surgeries have been. Was there any associated open injuries for an open ankle fracture? Was there any issues with osteomyelitis or infections in and around the soft tissues? You want to examine their gait to get a better understanding of any associated weaknesses. Look at their alignment all the way from the hip to the toes, areas of tenderness, neurovascular status, sensory status, and prior incisions, because all of this together will really play a role into how you're going to manage these patients from an ankle arthritis perspective. Now, you can get weight-bearing x-rays. We always want to get weight-bearing x-rays, and not just of the ankle, but you want to include the foot, because you need to understand how the foot lines up on the ankle in order to make sure that when you put a well-aligned ankle replacement in place, that the foot is lined up on that ankle. So we're going to get AP lateral oblique views of the foot and of the ankle. Now, oftentimes we'll also get what's called a Salzmann view, which is a weight-bearing heel view, to get a better understanding of how severe the varus or valgus deformity may or may not be. And then in the US over the last decade, and now you're seeing this percolate throughout the world, there are now these weight-bearing CT scans. And this has been very important to allow us to understand the loaded relationship of joints on one another, but also get a better understanding of the varus valgus deformity. And then you obviously get normal CT information from bony, your bone stock, as well as any cyst formation or things like that, which may be in consideration for your ankle replacement. Now, our indications for a total ankle really are ideally started out as patients who are less demand. So patients like rheumatoid arthritic patients, post-traumatic ankle arthritis, as they were older, with multiple joint disease, was really the ideal patient population. But as our experience has continued to collect over the years, we've expanded those indications, and so we've become much more progressive. I'm not going to say aggressive, but progressive about offering patients an ankle replacement option. So in our practice, in my practice today, active individuals, young individuals are patients who could get ankle replacements if they meet the criteria that I deem needed for it. Now, contraindications, talar avascular necrosis is still a contraindication, but I would say when I first started practicing, it was a absolute contraindication. Now it is a relative contraindication, and we'll talk about that in a little bit. Charcot arthropathy, neurologically compromised foot, and chronic infections are still absolute contraindications for an ankle replacement. So how do we do these ankle replacements? Well, this is kind of a panoramic view of my operating room, and on the left-hand side there, you'll see that I'm there with one of my fellows, and we're getting started. But there's a room full of reps, industry reps, who are there to help support the case. And on the right-hand side, you'll see multiple trays that are open to help support this total ankle replacement. So we've got a large C-arm, a big team. We're doing regional anesthesia, and it's a lot of coordination when you first start out doing these ankle replacements. Obviously, as you garner experience, it becomes more just practice and habitual more than anything else. Now, when you look at ankle replacements, there are two different ways you can approach these. You can do an anterior approach where the patient's placed supine. We make one finger breadth, one incision that's 1 finger breadth lateral to the anterior tibial spine. And we do that so that if the wound breaks down, which can happen, that you have some soft tissue protecting the tibia versus going just anterior to the tibial spine. At the distal extent of that wound, you do need to watch out for the intermediate branch of the superficial perineal nerve. If we see it, we mark it, we mobilize it, and we get it out of the way. You'll enter the joint, you prepare the joint, you put the trials in, you make your final implants. And at a very kind of high level, that's the way you approach the anterior approach. Some of these ankle replacements, or at least one ankle replacement that's now on the market in the US, takes a very different approach. It takes a lateral approach where, again, the patient's supine. You make about a 10-centimeter incision. You want to span the distal tip of the fibula, go all the way down to kind of halfway point to the base of the fifth metatarsal, tracking the perineals. And you want to take a proximal as well. You want to make sure that you don't see the sural nerve. But again, if you see it, you mark it, you mobilize it, get it out of the way. You then find peroneals, you get to the fibula, you do an osteotomy about 2 centimeters proximal to the joint line, and you'll reflect that entire fibula distally so that you can get into the joint. Once you get in the joint, you prep as you need, and you go ahead and you put your replacement in place after you do the trials. Again, a much different way to approach ankle replacement, but it is an option for patients who may have outstanding complications or outstanding issues in the front of their ankle so that you cannot do an anterior approach. The nice thing about the anterior approach is you can easily get coronal balancing, but the wound complication rate can be 10 to 30%, depending on what you look at the literature, and we can talk about some of the ways to minimize that. Whereas the lateral side, you do need to do a fibular osteotomy, so there's issues with that bone healing that can be problematic. In addition to getting that coronal balance, especially if you have a varus or valgus ankle, can become difficult from that lateral approach. So when we look at the market and the landscape, at least in the US, and it'll change globally, there is a question of, well, what implant do you select and what's on the market? Well, you really need to understand where we came from to understand where we are now. So these first generation ankle replacements that were on the market really did not respect the anatomy, the kinematics, the alignment, or stability of the ankle joint. And they took a lot of bone. They changed the level of the ankle joint. Some were very highly constrained. Others weren't constrained at all. There was poor cement fixation. And so you'd have implants that look like this, and I'll show you next in another minute, but these big bulky implants that failed because of multiple reasons, whether it was delayed wound healing because we didn't have refinement of soft tissue techniques, fibular impingement, loosening, malleolar fractures, these implants would fail. And so back in the mid-1900s, there became less and less interest in total ankle replacements. Now, as metallurgy has changed, surgical techniques have changed, implants have changed, we have had a renewed interest over the last 20 years in these ankle replacements. But again, if you go back, you'll see some of these implants were highly constrained, and that would become problematic. So a highly constrained hinge-like implant does not respect that ankle motion. And then you have something that's highly unconstrained, and then you could slosh and hit the malleoli, end up with malleolar fractures. And so these new generations really preserve bone stock. They respect more often the rotational axis. They try to respect the tibial foot alignment. Some are semi-constrained. I'll show you one that's not really constrained still, and they give you biologic fixation. So then the next question is, well, what surfaces do you replace? Now, we will always replace the tibiotalar joint, but some of these implants will also replace the lateral gutter as well as the medial gutter. And so there's no real good data or science on which is ideal right now, but these are some of the thoughts. Now, if you look at the laundry list here on the slide, you'll see that there are upwards of 10 ankle replacements on the US market by the end of this year. And I say that because some of these ones on the bottom of that center list are only recently FDA approved, and more are on their way. And so there is a varied number of implants you can do. And I'm going to touch upon most of these implants just to give you some background. So this is called a Salto total ankle replacement. It's basically placed into place by allowing your ankle to find its quote unquote sweet spot. So you're really ranging the ankle before you fix it into place, and that's how you find the axis of rotation. The data on this has actually been pretty good. 95 to 100% survivorship at about 5 years. If you track this out to about 11 years, anywhere from 85 to 93% survivorship. There obviously is significant improvement in gait. Survivorship is lower in lower volume centers, meaning if you don't do a lot of ankle replacements, your survivorship data tends to be worse. So from a patient perspective, you really want to seek out surgeons who are doing high volume to get the longer survivorship out of your implants. There is some concern with this prosthesis, with effect on talar body blood supply, cyst formation, subsidence, and talar collapse. Now, a lot of these concerns are not unique to this implant. You'll see this theme come back over and over again in some of these older implants that have been on the market for about a decade. But this is what an ankle replacement with a Salto would look like. This is a patient who has retained hardware. We then come to something that's more modular, that's something that's intramedullary. This is called the INBONE Total Ankle Replacement. This is one of my partners who's doing one of these ankle replacements. And this requires us to do an anterior approach, but put the ankle in a jig. Now that jig allows us to do an intramedullary drill bit right up the calcaneus, talus, and into the tibia. And then you can prep the joint like you need to and stack the implant modularly and be able to create an intramedullary stem as big as the surgeon would want. And so here are some of the cutting blocks. We'll go ahead and make our cuts. And it's a fairly large amount of bone that you'll take out, but allows us to really be able to do some bony balancing with, in addition to soft tissue balancing, to take patients who have large deformities like this valgus deformity, balance them up, do our cuts, do the intramedullary implant, and put it in place. The survivorship on this is about 90% at 6 years and counting as we get more data. So it's fairly good. However, again, there are some concerns. You're putting that drill bit up the talus, and so there's concern for talar blood supply. Cysts and loosening can be problematic. There's some subsidence and talar collapse that can develop if you hit the talar blood supply, which is some data to suggest that up to 10% of patients can have that issue, and then you develop talar AVN and collapse. The INBONE 1, which I'll show you a picture of, which is the first generation, has actually been shown to be an independent predictor of failure. So this company now has the INBONE 2, which is about 7 years out, and that data is more promising than the INBONE 1. But this is the INBONE 1 where it has a large stem going through the talus and really doesn't have small pegs in the front of the talus. But this patient of mine is now 10 years out and doing well and functioning fine, and so has beaten the odds so far based on that data. And we know data is obviously kind of the survivorship data is really a mix, an average of all the patients who were queried at that time. STAR total ankle replacement is a mobile bearing device. It at one time was the leader in the world for ankle replacements. It has two metal pieces, that plastic piece in between that floats in this little trochlea that's on the talus itself. That poly does float a little bit, so it gives you some rotation and gliding between the tibia and the meniscus, or the poly itself. And this is kind of what it looks like intraoperatively or radiographically after a patient has it. There are these two lines in the poly, these metal pieces, so that if the poly were to fracture, you'll see a discontinuity of the metal lines, and you know the poly is fractured. But you can have painful impingement in these patients up to 11%. You can actually have the subtalar joint be afflicted with talar AVN. So the talus basically dies, or resorbs. You get the talar prosthesis to subside. It impinges on the subtalar joint. And back in the day, we used to just go in and do a subtalar fusion to try to salvage these. And I'll show you some of the new techniques we're doing now. Now, this implant has been on the market almost 15 to 20 years, so we have good survivorship data. At 5 years, 85 to 96%. We started to erode that as time goes on. So at 15 years, you get 45 to 76% survivorship, and then at 20 years, you're getting anywhere from 55 to 91% survivorship, depending on the studies you look at. But this implant does show significant improvement in quality of life for the patient, and significant improvement in pain and function, and better function and pain relief compared to fusion itself. Now, again, same concerns, but when you put this implant into place, we take a lot of the talar dome away. So you worry about the talar blood supply, you worry about cyst formation, and with this implant, you cannot see directly under the talar dome. So because it actually resurfaces both the medial and lateral aspects of the talus, and because you can't see under it, on x-ray, there can be cysts forming that you miss that you'll only pick up with a CT scan. So that's going to be problematic. And then the problem is if you miss it, you get the subsidence of the talar implant and then impingement on the subtalar joint. Now, the Zimmer total ankle replacement is a lateral approach ankle replacement. It allows you, by coming laterally, to really nicely find that center of the ankle. It's minimal bone resection. You do need to put it in a frame, just like you did at the INBONE. This implant's only been on the market for about 5 years, so the data is slowly coming out. But the 2-year data shows 93% survivorship. 5-year data shows 97% survivorship, and we'll see how this goes. But again, there are some concerns. So here's a patient of mine who's 5 years out. I didn't have to worry about coronal balancing because they didn't have a varus or valgus deformity here. But if they did, again, with this implant, it becomes more challenging to balance the ankle. The bigger issues are fibular osteotomy. And you can see this patient actually does not have a painful non-union of this fibular osteotomy, probably has more of a partial union, but radiographically, every time I see this, it gives me angst worrying about the fibula and if it will ever become symptomatic. And then the other concern is that if you do need to revise these and you're coming from an anterior approach, can you easily pop these out? And I would venture that you could, but it is a concern that you may have. Now, some of the newer kids on the block, the Infinity is the upper right hand side picture. And then the Adaptis just was just was released over the last few weeks. That's in the lower bottom picture. The difference between the two, they're the exact same implant, but there is a surface that's much more aggressive for ingrowth on the tibia and talus on the lower picture versus the upper picture. The data on this, from our perspective, our institution was a little worrisome. The one-year data showed 90% survivorship, which was concerning out of all the implants that were on the market at that time. The 3-year data is showing 97% survivorship. Now, this is the data for the Infinity, that upper picture prosthesis, not the Adaptis, which is the newer implant that was just released. This implant and this company does come out with, does have patient-specific cutting guides, and there are some benefits that have been shown to some of these patient-specific cutting guides. You are able to shave operating room time. So if you look at this picture here, this is a cutting guide that gets put, you do your approach, you put the cutting guides on, and you make the cuts as you need to. It does save OR time about 23 minutes. It does save fluoro time about 73 seconds. And it is fairly accurate in order to get the patient's implants where you want it in terms of alignment and to predict sizing. And this is something you're going to see more and more from some of these ankle replacement companies, being able to provide patient-specific guides to make the operation, the surgery, more efficient. Again, our concern from our institution was early loosening, which you can kind of see here on the tibial tray. There's a little bit of a line that you can see, and this patient ended up going on to a revision. The Cadence is an implant that is been on the market for about 4 years. I am a designer of it, so to be fully transparent, I am one of the designers. It is an anatomic implant. It is sided, so there's a right implant, there's a left implant. It's minimal bone resection. The instrumentation to put it in is very, very simple. It's reproducible. There is a biased poly, meaning you are able to help push the talus either posteriorly or pull it anteriorly to help get the sagittal alignment, which you'll see is more and more important. And given all these options, there's over 670 combinations of this ankle replacement, more than anyone on the market, which means that although it's not a custom implant, it certainly gives you the closest off-the-shelf custom implant that's possible. And you can see here, the arrows are showing that incisura, basically to help the fibula nestle into place. And because there's an incisura on the tibial tray, you have a right or a left, and you can again see that on the CT scan that the tibia is not flat on that lateral side. It does have an incisura that helps to nestle the fibula. The polys can come biased, so you have a neutral or an anterior posterior bias poly, which becomes important in a patient like this. If you see on the left x-ray, there's an anterior subluxation of that talus. But after the ankle replacement is put into place using the anterior bias, you can push that talus to the back and basically center that talus on the tibia again. And we're recognizing that this is more and more important. And so this is a patient who had a posterior bias put into place and helped to pull the talus anteriorly to get that sagittal alignment that is so important. Now, our 2-year data is showing 100% survivorship. This is coming out of one of, not our institution, but another institution with a design surgeon as well. And we're continuing to follow these patients up. At this time, there's no flat top, which some of the implant companies have. There's no revision system, but that will be changing over the next few years. This is another implant called a Vantage ankle replacement. It is anatomic. It's also minimal bone resection. The difference here is the pegs on the tibia are more axial. The thought being that if you get more axial loading, maybe you get more ingrowth. The talar preparation can be difficult on this. The talus fixation sometimes can be difficult on this, and those are some of the challenges with this. And in addition, as you try to impact the tibia, you can fracture those malleoli, and I found that that can be problematic. The data on that is not available yet, only because that implant's been on the market for about 2 years, and so look for that data to come out. The newest kids on the block that have been FDA approved in the US this past year are these two implants here. They're not, have not been implanted yet, but we are looking to get experience on this over the latter half of the year. The selection of the implant, in my mind, has become fairly crystal clear, but it's not necessarily based on the implant itself as much as the features of the implant with the newer generations. So I broke this up as under 40 and over 40 because that used to be the old way of thinking. In my mind, it doesn't really matter anymore. So I don't use the mobile bearing device anymore because of some of the cyst issues and because of the talar avascular necrosis issues. I use minimal bone resection implants, whether it's the Cadence. I don't really use the Vantage very often. And some of the new kids on the block, I don't know yet, just because they're not available. The Zimmer implant, I will keep as a reserve for those patients who have anterior ankle issues, soft tissue-wise, that I want to come to the lateral side. And if I have a patient who's heavy, whether it's 300 pounds or more, or have a revision that I'm doing, or have a very big deformity, then I will consider doing the intra-medullary device with the Inbone. So the indication for use for my patients now is no longer just this optimal patient, but I will go into the relative indications for youthful and active individuals. And I've had a rare case where my youngest patient now is 14 years old. Rare case, there was a specific reason to do it, but 14 years old at the time of doing the total ankle replacement. The outcomes for ankle replacements in general, these patients have better mechanics than patients who have ankle fusions. They walk more normally, obviously because they have motion. They do require more surgeries, which makes sense because this is a joint replacement. And whether you have impingement or heterotopic ossification or a revision or wound complications, there are things that are going to come up for the ankle replacement patient that just don't happen with ankle fusion patients. But their gait patterns, their up and go patterns, seated from a chair and going, are much better with an ankle replacement versus an ankle fusion. And so here's my one of my patients who is 7 years out. She's given us permission to use this video. And you can barely tell which ankle has been replaced. It's her left ankle. She does run 4 miles a day, which I don't espouse, but she does it because she's trying to stay fit and really running is her passion. But these patients can do well. So the whole theory about ankle arthroplasty in young, I think there's a real benefit to these patients. When they're young and they need range of motion, they want pain relief, and they're more active, we want to give them that motion. And so I believe that those benefits outweigh the risks of the need for multiple surgeries or revision surgery, and the risk for conversion to fusion. And we've gotten better at being able to convert these to a fusion. There is an ideology out there that you fuse them when they're young, and as they're older, you take down that fusion and you give them an ankle replacement. And I would argue that that's probably not the best thing to do, because when you fuse them, you'll get muscle atrophy, you'll get adhesion formation. And whether that's a fusion for 3 years, 5 years, 10 years, to then put an ankle replacement in place and try to get all of that mobile again becomes challenging. And there's data to suggest that those patients who get converted from a fusion to an ankle replacement do not do as well as those patients who get an ankle replacement off the bat. And so for me, the benefits for an ankle replacement in the young are much bigger than the risks for future issues. So for me, I'll do anybody who's even in their 20s, they've got good skin, they've got an adequate talus. I will do it even upwards of a deformity up to 30 degrees. And now I'll start doing avascular necrosis. And again, we'll touch upon that in a minute. So here's a patient who I did a takedown on, had a painful non-union, really didn't like this non-union. We went in and did a star ankle replacement. This patient's about 6 years out and has done well, but the pain relief is not as good as had I done an ankle replacement right off the bat. Now, the real other question is what happens when it fails? So here's a patient of mine who had a triple arthrodesis, came in about 2 years later, had an ankle replacement done because of ankle arthritis, and I used a stem prosthesis. Lost the patient to follow-up. That usually means they're doing really well. Well, then he comes in about 7 years later, and that usually means they're not doing so well. And what you can see from this lateral x-ray is that talus has subsided. The talar prosthesis is now much lower, and the patient is having more pain, more dysfunction, more disability, and has lost some motion. So he really didn't want to get an ankle fusion or convert it to an ankle fusion. And so what we did here is we 3D printed a new talus and gave him back his motion, and he's back to playing golf and doing well, has 1 out of 10 pain. So he has done well. But so for my patients who now have talar avascular necrosis, we can offer them a total talus replacement with an ankle replacement off of any of the total ankle replacement systems, a tibial replacement side, and we can give them a combination total talus ankle replacement. And we have about 25 of these percolating in our system. We are now pioneering some really big changes over the last 3 or 5 years with pain management and better control, PT evaluations occurring the same day of surgery so that we can get these patients using regional anesthesia out the same day. So it's same day total ankle replacement. And if we can do that, and we've done that already, about 75% of my total ankle replacements are same day ankle replacements, you can give them the comfort of recovering in their home the same night, and you can achieve cost savings. So in essence, at the end of the day, ankle replacements are increasing in popularity. Ankle design and technique will dictate what works to obtain a good result. Surgeons in general will find systems that they like and that they're comfortable with, that they can get reliable results. We are expanding the capability of ankle replacements, and we are starting to do that, expanding indications for age, for pathology, and we're getting reliable results with this. So welcome to the 21st century. Ankle replacement should be in your wheelhouse for treating these patients with ankle arthritis. Thanks.
Thank you, Selene. Excellent presentation. You can actually stop sharing your screen, or, I mean, it's up to you. Few questions. Now you have showed a lot of implants from the 3rd generation, right? So there's going to be heterogeneity in outcomes. So does it call for a registry? Do you have an ankle replacement registry?
Yeah, so you are absolutely correct that a registry is critical. The problem here for us right now in the US is that has not happened. If you look at the European colleagues, they have established registries, not a European registry, but national registries in different countries. That will happen in the US in the next 5 to 10 years. The problem for us is that the heterogeneity, obviously, but that can be managed with a database. The biggest issue is the cost and the agreement of data that needs to be collected and how that gets entered. And then that really all boils down to cost and who bears that cost.
And the lateral approach, you mentioned the Zimmer Total Ankle Replacement. Is that a trabecular metal component?
It is a trabecular metal component. And the thought being that you get better ingrowth with that. And some of the newer implants are integrating some of the type of trabecular metal implants on the on-growth surfaces.
And suppose you have an associated subtalar fusion that is there earlier. And how do you think are going to be the outcomes? Because some movement restriction is going to be there. So do you think that's going to affect outcomes?
I don't think it affects outcomes because, you know, as we know, the subtalar joint will affect about 40 to 50% of your inversion eversion. So they'll have, with ankle replacement, they will regain some ankle motion. And in fact, they like that. And the subtalar motion loss really doesn't affect them. I have not found that to be problematic. And in fact, even patients who have done a triple arthrodesis on with an ankle replacement still do very well, because really for everyday activity living, you really need that plantar flexion, dorsiflexion more than you need the inversion eversion.
The other concern is, suppose you have a lower extremity malalignment. Have you encountered a scenario where you need to do a concomitant procedure?
Oh, absolutely. So that is something that you would need to be very, very comfortable with. And it's one of the reasons why ankle replacement still is in the hands of the foot and ankle surgeons, because you must, I cannot emphasize it enough, you must balance that ankle before you start making your cuts for an ankle replacement. And whether it means you're going to do a supramalleolar osteotomy, you're going to do a calc osteotomy, you've got to do a dorsiflexion osteotomy of the first ray, you've got to balance the ankle, and then you've got to balance the foot on that ankle. And that means you've got to be comfortable doing all these different procedures to do that. Because otherwise it's like putting a brand new tire on a malaligned car. If your alignment on your car is off and I give you a brand new tire, you're going to rip through that new tire. It's the same thing. And so you've got to balance. And so I tell you about anywhere from 20 to 30% of the time, I'm doing an associated procedure to balance the ankle.
And how about doing a concomitant ligament reconstruction, the medial side or the lateral side? Have you encountered that scenario?
Yeah, very much so. And so for me, that's kind of part of our associated procedures. Much more often, we have to do a lateral ligament reconstruction than we do a medial ligament reconstruction or an allograft reconstruction. And for some surgeons, the medial deltoid compromise is a reason not to do the ankle replacement, right? Because we even don't have great ways to reconstruct the deltoid. But we will routinely do lateral ligament reconstruction, and less often, thankfully, do we have to worry about the medial side.
The other question is the location of the incision. Do you look at the angiosomes? There's a lot of debate happening on the location of the angiosomes and the placement of the incision with respect to the angiosomes of the foot and ankle. So what is your take on that?
So it does seem that incision one finger breadth lateral to the tibial crest is in between two angiosomes and will allow for less impact on the angiosome. The problem still is that about 10% of the time, and if you look at the literature, some of the older literature suggests up to 30% of the time, there are some wound healing issues. And so we have really combated that with some ancillary things. So I will actually put some amniotic tissue right in the subcutaneous tissue before closure. That decreases adhesion formation. I think it does help with wound healing. We'll actually do a soft tissue expansion device, and we've got some on the market here in the US, which basically takes pressure away from the incision and helps to minimize the tension on the incision itself. And then I'll even use an incisional vacuum dressing to help close that wound. And all of those techniques have taken our wound complication rate down to less than 1%.
And all your implants currently, are they cementless or cemented?
Uncemented. Uncemented. So that's a curious question because the FDA in the US has only approved the STAR as the only ankle replacement that is not does not need to be cemented. All the other ones have only been approved with cementing, but we routinely do not cement these implants in place.
If I remember, Professor Hinterman has developed processes, right? H2 or something like that, and
yeah,
it's like a cementless one location and cemented outside US. Is it something? There's something different.
Yeah, exactly. And it entered the US market about 2 years ago. It does not have any data in the US. When it launched in the US, it did need to be changed a little bit. And so when it was changed, the data now of the Hintegra globally really shouldn't be translated to what we're seeing in the US, only because the implant's a little bit different.
I think thank you, Selene, for those replies to those questions. Thank you once again for joining us. It has been a very great honor to have you on board. It is such an enlightening lecture. I think that's all the questions that we have for the session. Thank you once again for joining us, and we really look forward for some of your talks in future.
Thanks, Adesh. Appreciate it, guys.
Thank you. Bye-bye.